Well said, sir. Thank you very much. We'll be opening it up for the senators to ask questions and offer comments here as soon as the panel has an opportunity to be able to speak. We're now going to be turning it over to Ms. Stahl from the Alliance for Child and Family Services, and we welcome you here today, and thank you for taking time out of your schedule.
Good afternoon. My name is Dr. Lynn Thal, and I work for the California Alliance of Child and Family Services. We are a statewide organization of accredited nonprofit organizations which provide services to children and youth throughout the state. My specific role is to provide advocacy and also to consult on issues of quality services to children and youth. I'm also a practicing licensed clinical psychologist focusing on children and families, and so I'm going to talk from both a policy perspective and a clinical perspective. To ensure that children's behavioral health needs are successfully addressed, we must ensure that the right child gets the right treatment in the right amount, at the right time, and in the right dosage. This applies to psychotherapeutic services as well as medication services. The issues involved in prescribing psychotropic medications to youth, especially the youth in foster care, are very complex. And the use of psychotropic medications to foster children and youth is not a new issue. We at the Alliance have been involved in this, at least 3 prior legislative efforts to monitor and restrain the use. The rates, however, have not declined. Taken in isolation, the rates of prescribing psychotropic medications to youth are alarming. The problem is that we don't know the context behind these numbers. We have no data to tell us if the children are better or worse off on or off the medication. What we have are anecdotes, sometimes very chilling anecdotes. But we also have quantitative data, but we have no qualitative data to tell us what this means. To better understand the utilization rates of psychotropic medication with foster youth, we need to know who's prescribing, where the prescriber and youth are located, what's being prescribed, and for what goal, what alternative or additional therapeutic interventions were available to the treatment team, and were they actually tried. And most importantly, we need to know the functional outcomes of the youth to whom the medication was being prescribed. In other words, is their function improving, worsening, or staying the same? Moreover, system challenges are contributing to questions related to the use of psychotropic medications, and they include a lack of a mental health policy that focus on quality services for children and youth. Virtually all changes to children's behavioral health policy in the state is the extension and to the extension to foster youth has been driven by litigation and budget. Also, lack of integration between public child welfare and children's mental health systems has contributed to these challenges. County child welfare agencies are tasked with ensuring the safety and well-being of children who've been removed from their parents, and county behavioral health agencies increasingly see children as beneficiaries of their managed care health plans. The recent KDA settlement agreement sought to bridge this conceptual and policy divide between public agencies with a shared management structure. However, those efforts have been significantly delayed, and they lack policy guidance from the state. Also, the lack of assessing a complete therapeutic continuum of care, regardless of where the child resides, continues to be an issue. A county in which the foster care or youth resides determines services that are available to that individual. This challenge potentially increases the use of medications, as well as the length of time the child is on those medications, because with the one mental health service virtually every foster child has access to is medication. Additionally, the average amount of time and intensity of special mental health services provided to youth has decreased in recent years. For example, the most recent data from DHCS shows that children who are prescribed psychotropic medications receive on average 5 hours a year of med support. A year. So that med support includes not only the time of the physician prescribing the medication, but the time in assessing, the time in coordinating with the team, the time in filling out the JV-220, TAR, any other necessary document, follow-up, and coordination with the team after they've prescribed the medication. At the same time, the average amount of time and intensity of non-medication, especially mental health services, has also decreased. Finally, California continues to move to a managed care model, And we've seen disturbing trends toward a one-size-fits-all approach focused on brief, clinic-based service. This model offers no services and supports to the foster family or to the family members or other individuals that the youth feels is supportive to their well-being. For example, treatment codes that reflect the full array of services that we currently get in the especially mental health services aren't even available in the managed care system. To address these shortcomings, we need a policy driven for kids' services, not being driven by litigation. We need to stop treating kids like little adults or simply beneficiaries of a health plan. Kids have unique needs, particularly children involved in the foster care system. There are specialized evidence-based practices developed for children, youth, and family, and services should be provided by specialists for children, youth, and families, especially those in foster care. We need to ensure that alternative and collateral therapeutic continuum of care is available to every child, regardless of where they live in the state. This includes a thorough assessment of both strengths and needs of both the youth and their caregiver. We also need to include a team approach in the development and revision of any care plan, if it contains medication or not. We need consistent data, and data that is available to all stakeholders in a timely manner. And it must be transparent. And we need accountability at all levels of care.
Doctor, thank you so much. Grateful. And a brief editorial. The 5 hours per year is what really sticks out. And we are just having that discussion in regards to medication versus true mental and behavioral health and access is critical. So thank you.
Thank you.
It is now our pleasure to be able to introduce Brenda Parrish. We are excited that she's coming to us from beautiful Alameda County, and she's a public health nurse, and we're grateful that you're here today. Thank you so much.
Thank you, Senators, for having me. As you said, I'm a public health nurse with Alameda County's healthcare program for children in foster care. And I began my career in public service with the Social Services Agency as a child welfare worker in Child Protective Services. Transferred to public health, have been in public health for 16 years. For the most recent years as a public health nurse, conducting assessments and assuring that families have medical coverage, that they have a medical provider, and that they receive appropriate and scheduled health care. Now, in Alameda County, we have 6 foster care nurses, and they are assigned to 1,500 foster children, and that's an average of about 300 cases per nurse. And a few of our challenges are that we don't have the inability to monitor psychotropic medications the way that we would prefer because of that caseload. Another challenge is the break in Medi-Cal when there are changes in placements. And lack of access to data. In order for us to be able to efficiently monitor psychotropic medications and to protect the health of foster children, our team would recommend that a collaboration between the Social Services Agency, Behavioral Health Care Services, and the Public Health Department to form a distinct multidisciplinary unit consisting of a child and adolescent psychiatrist, a pharmacist, a CHDP pediatrician, licensed therapist, child welfare worker, and a dedicated group of public health nurses to really provide comprehensive oversight and timely reporting. Thank you.
Thank you so much, and do appreciate that, the list, and that's going to be very helpful as we come back in the fall as well. So thank you so much.
You're welcome.
It is now our pleasure to be able to introduce Judge Michael Nash. He is now retired, but he served many years on the Superior Court in Los Angeles County, and we are grateful that you are here today and for all of your work and advocacy, sir.
Thank you, Senator, and other members of the committee. I'm happy to be here with you today. I'll try not to be too redundant because we've heard a lot today, and you can really, in many respects, can't help but be a little bit redundant. So let me just start by saying this. Based upon everything we know and that we've heard, the bottom line is we have to be very careful and vigilant when and if we use psychotropic meds on children. And for our purposes, whatever we do, remember that we're doing this one child at a time. I know there's a lot of systemic issues that have been addressed, but at the end of the day, we're talking about one child at a time. And when we're talking about one child at a time in the use of meds, I submit that what we need to do is essentially attempt to put ourselves in the shoes of a prudent parent. And as a prudent parent, there are a number of things that you're going to do. Number one, you're going to know why you're bringing your child to the doctor in the first place. Secondly, you're going to make sure that the doctor is qualified to deal with the issues that you believe that your child has. Third, you want to make sure that that doctor does a comprehensive examination of your child. You want to know what that doctor's ultimate diagnosis is, and then, what are the treatments? Are there alternatives to medication that can be used for your child? And if medication is necessary, what are the likelihood of the variety of effects, both positive and negative, that that medication can have? And are there other treatments that you want to utilize in addition to the medication? But the most important thing of all, when you talk about a prudent parent, is as a prudent parent, you know all of the nuances of your child's behavior, and you're going to be watching your child like a hawk to make sure to see if there are any changes, both positive or negative, in your child's behavior based upon whatever treatment you're starting to utilize with your child. And of course, you want to make sure that you maintain a relationship with the prescribing physician as time goes on. So how does the system that we talk about meet this standard, whether it's a child welfare system or the juvenile justice system? Well, we know that most of our children in care are with people who don't know them. We also know that one of the banes of our existence in these systems is the fact that children change placements way too often. While the number of children in group homes has significantly declined over the years, which I think is we should recognize that, and that's a positive thing. At the end of the day, we also know that group homes basically have the worst outcomes for our kids. And the question with group homes, among other things, is who is watching the children? Who is responsible for administering the medication and monitoring the effects of the implementation? The doctors who prescribe the medication, who's checking on their credentials? Did that doctor even see the child and do a comprehensive examination of the child? And ultimately, the question we ask ourselves, are the medications being used for control of the child's behavior or treatment? We also know that within our systems, the decisions to approve the use of the administration of the medication is done by judges. And of course, the last time I looked, I couldn't find any psychiatrists or psychologists on the bench, no matter what some of my colleagues may tell you. And so the question is, who's giving medical advice, or who are the judges consulting with when they decide to approve certain medications? Has the judge actually even seen the child in court to talk to the child about the medications? And really that varies from jurisdiction to jurisdiction. We know that the judge makes that decision on the basis of the JV 220A form, which has a lot of information on that form. But the question that I ask is, who is verifying that the information on that form is accurate, and how is that verification occurring? And I will tell you this from my experience, that judges receive little, if any, input from the attorneys who work with kids and families, the social workers, the probation officers, and others. And, they often say, well, look, our caseloads are just too big. We have too much work to do. This is a difficult issue for us. And yes, everybody's caseloads within these systems is too large. But I reject that argument with respect to this issue because this issue is too important to fall back on workload. This is a priority issue that we just have to address regardless of what our workloads are.
And Judge, you have about 2 more minutes.
Right, okay, so let me just, I'm almost done. I'm going to go through this real quick. Once the medications are approved, the question is, okay, who's doing the monitoring? How are the meds being monitored? Who ensures that the medications continue when children change placements? Because we know that when they move, or if there's a break in the regimen, it can be very harmful to the children. Are we engaging the children and the caretakers in this process so that when so many of our kids reach the age of 18, they're capable of making decisions for themselves? So at the end of the day, unless this whole village, everybody that's affiliated with the children within these systems participates and is engaged in the process, we'll never come close to meeting the appropriate standards. So let me just give you my quick list here. You wanted 5, I actually have 6 or 7. Okay, number 1, I would start with saying that the recommendations by the National Center for Youth Law are a good start. But I also think that, you know, when you look at that 220, JV 220 form, a lot of what's on that form really needs to be mandated, okay? And by that I mean things like, all right, there needs to be a mandate that there actually be consideration of alternatives in lieu of or in addition to the use of psychotropic medications. We need to mandate that there be consideration of the youth's medical history, including the prior use of medications. We need to mandate that there be a monitoring plan which includes identification of responsible persons, including or especially children who are in congregate care. We need to mandate that there are regular medical follow-ups for the child consistent with a reasonable standard of care. We need to mandate that there are procedures in place to ensure the continuation of the medication when a child changes placements. We need to mandate that there be youth engagement in the process that's targeted at preparing youth who reach the age of majority to be able to make or handle their medical affairs related to the use of medication, including whether to use the medication, how to obtain the medication, how to maintain a relationship with a prescribing physician. And lastly, we need to mandate that there be more comprehensive assessments when we're prescribing certain classes of medication for our children, including antipsychotics, that there be more comprehensive assessments when someone's prescribing multiple medications, and mandate that there be more comprehensive medications when they're being prescribed for children who are under a certain age. Thank you.
Thank you so much, Judge, and do appreciate those recommendations being brought forward as well. And if we could follow up with you on those in writing too, that would be fantastic.